Today's Pearlcast, we're going to talk about in vitro fertilization, or commonly known as IVF. Now, these Pearlcasts are typically 7 to 10 minutes, and to try to get through all of IVF in that amount of time is difficult, but we'll certainly do our best. So, in vitro fertilization started back in 1978 when the first baby from IVF was born. Her name was Louise Brown over in England. Since that time, IVF has taken great strides with increasing success rates. So what are the reasons that we do IVF? Couples come to the fertility specialist for a number of reasons, and in order to evaluate them fully, we do a number of tests that can be discussed at a later date, but we will talk about the reasons for IVF being tubal factor infertility. Are the female's tubes abnormal? Male factor infertility, when a male of the couple has a semen analysis, are there abnormal parameters? Endometriosis, which causes subfertility and certainly can cause adhesions in the pelvis, and adhesions in the pelvis can cause tubal factor and obviously prevent them from achieving a pregnancy. And then also IVF is done for unexplained infertility, where this means the couple has gone through a number of tests and hasn't come up with a reason for them not being able to have a child. So how is IVF done? In a typical normal menstruating woman, the pituitary gland of the brain sends out gonadotropin signals to the ovaries. And there are inherent checks and balances in this system called the HPO axis, which is the hypothalamic pituitary ovarian axis. There are checks and balances where in a normal menstruating female only one egg is produced each month. Well, in IVF we want multiple eggs. So in order to do that, we have to block this HPO axis from the pituitary talking to the ovaries in order to take control of the ovarian stimulation. To quiet the HPO axis, we typically use OCPs, or birth control pills, or we also commonly can use Lupron, which is an injectable medicine that further suppresses the pituitary gland from sending the gonadotropins, LH and FSH, to the ovaries, as mentioned in the previous diagram. Once this is complete and we have shutdown of the ovaries, we will ramp up the stimulation by having the patient take injectable forms of the exact same pituitary hormones, the LH and FSH, in liquid form. From there, what happens is, if you look at their ovaries on ultrasound, their follicles, or the cysts on their ovaries that can actually contain the eggs, will be subjected to these injectable gonadotropins, and you'll see larger and larger follicles develop, and that means there's maturation of the eggs. These are monitored with ultrasounds and blood draws because we need to know what these antral follicles are doing, what these follicles are doing and how well they're maturing to see if they need an increased dose of their stimulation medicine. As the patient continues on with the monitoring and we're further looking at her ovarian follicles and maturation of her eggs, there will come a time when they are fully mature, and typically this is about 9 to 12 days of those gonadotropin injections to get mature follicles. At that time, we are ready for the egg retrieval. The egg retrieval is done under sedation, and if this is the vagina here, what happens is an ultrasound probe is inserted into the vagina to see the ovaries, and a needle is injected into the follicles through the vaginal wall here on either ovary. And the follicles are aspirated where the eggs will come into the tubing and be taken to the lab. The same day that the egg retrieval is done, the male partner will collect a specimen to have sperm available for the fertilization in the lab. For fertilization to occur in the lab, there are two ways we go about doing this. One is called simply traditional IVF, where in the laboratory there's a dish and an egg is placed around it, and thousands of sperm are placed around the egg in hopes that one sperm will find the egg and fertilize it. Whereas in ICSI, which stands for intracytoplasmic sperm injection, this is done for folks who have severe male factor where there could be a sperm issue. What happens in that case is the egg is taken with a micromanipulator and one sperm is actually injected into the egg for fertilization. Because the idea is if there's severe male factor on the sperm side, then the idea of fertilization may not occur is very high, and therefore we try to overcome this with this ICSI procedure. The rate of success for fertilization with this is usually 70 to 80% fertilization rate, which is an excellent rate. After the retrieval, we're able to tell the patients how many eggs we were able to retrieve, and the very next day we tell them how many fertilized and how many embryos we have. From there, we simply follow the progression of the embryos. And typically what happens on day 3 of development, it looks like this, where this is a day 3 embryo with what are called blastomeres, and there's usually typically 8 blastomeres in the embryo at this point in time, and we take a look at them at this stage. Typically, transfer of the embryos, so placing the embryo or embryos back into the uterus, is done on day 5, and this is called a blastocyst. And in this blastocyst, there's something called the inner cell mass, which will become the fetus, and the trophectoderm, which will typically become the majority of the placenta. When it's time for the transfer on day 5 with the blastocyst, the transfer is done with a simple catheter that holds the embryos. And if this is the uterus in a sagittal view, so a side view, cervix is here, this is the lining or the endometrium of the uterus, the catheter is simply passed through the cervix into the uterine cavity to the thickest part of the lining, and this is all done under transabdominal ultrasound guidance so we can see where the catheter is going in. And typically it's about 0.5 centimeters or thereabouts from the top part of the uterine lining. But again, it's in the thickest part of this endometrium. Now the question is, how many embryos do we typically transfer? Because in IVF, the goal is not only to achieve a pregnancy, but obviously, hopefully, to limit the amount of multiple gestations we produce. So we have guidelines by ASRM, or American Society of Reproductive Medicine, based on age as to how many embryos we can transfer, or it's recommended to transfer. A female less than 35 usually only gets 1, maybe 2 embryos transferred. When the age goes up, 35 to 37, you can do 2, possibly 3. And as you go to 37 to 39, 3, possibly 4. And over 40, you can do 4 or more. Now, this is mirroring in nature what happens as women age. It gets more difficult to get pregnant, and because of that, we try to improve the rates by transferring more embryos. In a natural pregnancy, what happens after ovulation and implantation, the ovary that produced the egg that was fertilized has a corpus luteum that produces progesterone, or P4, among other things. Obviously, there's a lot of estrogen around as well. However, in IVF, because especially if we've used the Lupron to quiet the ovaries and with the egg retrieval, this isn't always produced at sufficient levels from this corpus luteum in the ovary. So therefore, we have to have the patient take these hormones to ready their uterine lining for proper implantation. What happens is both of these hormones will feed the uterine lining for proper implantation once the transfer is done. 12 days after the transfer, they do a pregnancy test or an HCG blood level to see if it's positive. If the HCG test is positive and they are pregnant, we have to continue supplementation of this estrogen and progesterone, either with patches of estrogen or pills, or we can do injections or vaginal suppositories of the progesterone. To have confirmation that they are pregnant with a positive HCG test, they will come back for an ultrasound between 6.5 and 7 weeks gestation. And what we're looking at with this ultrasound is a yolk sac, which is inside the gestational sac, and what's called the crown rump length of the fetus. We take measurements of both the yolk sac, the crown rump length, and obviously fetal cardiac activity to to assure viability of the fetus. Obviously looking at numbers of gestational sacs as well to see if there are in fact more than one, and counsel the patient appropriately if they do have multiple gestation. We have confirmation of a viable clinical pregnancy on the ultrasound at 6 to 7 weeks. The patients will continue their estrogen and progesterone supplementation to further allow viability of that pregnancy to hopefully continue. They will do these medicines until 10 weeks gestation. Now, 10 weeks is not picked out of thin air. There's a scientific reason for that. And if you remember, in a natural pregnancy, when the ovary releases an egg, the corpus luteum is making these hormones. Well, we know that in natural pregnancy, at 10 weeks gestation, the placenta has taken over production of these, and so that's why we choose to stop it at 10. The patient will choose to stop this at 10 weeks gestation. We have proven viability between the 6.5 weeks and 7 weeks gestation. The patients will usually be referred back to their general OBGYN for obstetric care in hopes of the pregnancy obviously to continue to delivery. The chance of a miscarriage after we see those three things on ultrasound, the yolk sac, fetal cardiac activity, and a normal crown rump length, the chance of miscarriage decreases to less than 10%, typically less than or about 5 to 9%. So obviously this is a very good sign at this gestation to see these three things. We've gone over the process of IVF and the further ultrasounds in pregnancy. It's important to realize a few things. One is IVF is really all about numbers, and then what I mean by that is at the time of the retrieval, when we're getting the eggs, we try to get as many eggs as we can, because not all those eggs will be mature, not all those mature eggs will fertilize, not all those fertilized embryos become a pregnancy. So what we have is an attrition at each step of the process. So what we try to do is get as many eggs that's safe for the patient, because we know at the end there are not going to be as many embryos to transfer. Now, oftentimes in cases of IVF, we will have excess embryos or blastocysts, and in that case we do cryopreserve or freeze the embryos, because any excess embryos they can come back for in what's called a frozen embryo transfer cycle, or FET. So if they were pregnant on their transfer and they want to come back for a sibling to that child, they have embryos frozen. The flip side of that is if they weren't pregnant with their first transfer and they still have frozen, they obviously can come back for those frozen embryos at a later date and hopefully get pregnant that way. Another common question that's asked is what are the side effects? And the main side effect of IVF that we look at is something called OHSS, or ovarian hyperstimulation syndrome. Now this is where the follicles of the ovaries with the gonadotropin injections that the patients are taking produce a lot of estradiol, or E2. And what this does is it causes the patient's vessels, vasculature, to get leaky in the third space fluid. And so the typical symptoms of this are abdominal girth swelling, pelvic distension, nausea, vomiting, and it can get to the point where there can be some electrolyte imbalances and coagulopathies, but that is exceedingly rare. This is the main reason, one of the main reasons, we monitor the patients, as described earlier, as they are taking their gonadotropins to stimulate their ovaries, because we want to try and prevent this as best we can. So in conclusion, as an overview to IVF, the main points I'd like you to remember are the HPO axis, or the hypothalamic pituitary ovarian axis, is essentially quieted or shut down through medicines, either birth control pills or the injectable Luprons, and then we as physicians and the patients themselves will ramp up the stimulation of the ovaries to produce a number of eggs with the gonadotropin injections, or the luteinizing hormone and FSH injections. The egg retrieval is then done once the proper size and maturity are revealed on the ultrasounds and the monitoring scans throughout their IVF cycle, and it's done with a transvaginal approach with a needle through the vaginal wall into the ovaries themselves to aspirate the eggs. The embryo transfer is typically done 5 days later, and the number of embryos that we transfer, remember, is based on age typically. Any excess embryos are frozen to come back for an FET cycle, or a frozen embryo transfer cycle, and the main thing we want to look out for is OHSS, or ovarian hyperstimulation syndrome, and we do this with the monitoring scans that I mentioned before throughout the IVF cycle while they're taking the injectable gonadotropins.